So, welcome to the Golden Jubilee series. Today is day 7, and today we are going to discuss a very interesting case. It's a post-traumatic lens subluxation with cataract. So, this patient, you can see that there is zonular dehiscence here and about grade 2 nucleus sclerosis. So, the patient had sustained trauma, but being an elderly person, he also had some amount of nucleus sclerosis. So you can see the side port being made through the using the 20 gauge MVR blade. So side port incisions on both the sides, almost 180 degrees apart. So because of the presence of the zonular dehiscence, it is advised that one should not use trypan blue, because trypan blue would go behind from the zonular dehiscence. This area, since there are no zonules, the trypan blue can go behind and the glow will just vanish. And since there is good retroillumination, I decided not to use trypan blue at this point of time. This is a 2.2 millimeter incision, and the keratome being used, slight enlargement to 2.4. Here I am sitting superiorly. The reason being is that because of the zonular dehiscence being here uh, in the inferior part, I am sitting superiorly rather than my usual technique of sitting temporally. And now the rexis. So the rexis is a challenge. You can see that the lens tends to tilt, and you can see the anterior capsule is lax. So the challenge is first in these subluxated or patients with zonular dehiscence, one has to be very careful while doing a rexis. Many a times one can accomplish rexis if there is a limited zonulopathy using the cystotome, but many a times one has to resort to using forceps. Here you can see that I have been able to complete the rexis with the cystotome itself. So here you can see that I have completed it with the cystotome itself. One should not attempt to make a very large rexis in these cases. 5.5 millimeter rexis will do. And then what I'm doing is I'm putting viscoelastic in the capsular bag. And that is because I have planned to put in the CTR right at the very beginning.
Okay.
Yes. So I'm creating some space between the cataract and the capsular bag to allow the CTR to go in easily. And since this video is slightly long, so I'm going to bring it up a bit. Okay, now you can see the loading of the CTR. This is a,
Yes.
let me just go back a bit. Okay. What you're seeing here is this is a Madhu CTR injector. This is the CTR ring, and there's a hook at this point. So the hook is meant to engage the eyelet of the CTR, and then this is simply pulled inside. It's like a routine your inject. The CTR just simply goes inside. In this case, however, because the CTR, this is very soft, so I was having difficulty in putting it inside. So then I changed. Now, just stop it here. Okay. I was having difficulty in injecting the CTR with that soft piece. So now what I'm using it, this is a Epsilone and a Epsilone CTR injector. It is made of stainless steel, more rigid, and probably gives better control. This also has a, you can see here, there's a hook here, and you just engage the eyelet with that hook and allow it to just go inside. So this goes in almost completely. Just the eyelet you can see over here. Now this is taken and sorry, just let me go back. Now this is introduced into the anterior chamber, and this is my preferred technique of the way I put in the CTR. What you will see here is that I'll stop here. What you will see is that I will hold the eyelet of the CTR. Now here you can see I'm holding the eyelet of the CTR, and then pushing in the CTR while still holding this eyelet with the Sinsky, allowing the CTR go in the capsular bag, and this CTR, this segment is brought closer to where I intend it to be, and then released. There you can see me releasing. Now I will release it there. So what this technique does is that it puts lesser stress on the zonules while this CTR is being placed in the capsular bag. Now, because the pupil has come down a bit, but this part of the capsular bag is now pushed away. Now I will use trypan blue. I will put the trypan blue over the anterior capsule and allow it to stain. Now, of course, you will not get a stain as good as what you would under air, but you will still get some amount of staining of the anterior capsule, and then your capsular, your rexus will be visible. So you can simply visco express out the excess amount of trypan blue, and much of the trypan blue has been expressed out from viscoelastic over the cornea, just to increase the visibility. You can see the rexus. You can see the edge of the rexus here.
कैसे टंगाई है हेमंदा को श्रद्धांजलि देते हुए
You can see the edge of the capsular rexus here, and I'm just making a nick over here using a macro scissor. So there I've got an edge. And then using the Purkar forceps, some sodium hyaluronate to have a good anterior chamber. Since I'm going in through the main incision, and then holding that edge of the anterior capsule where I've just cut it. There you can see that I've got a flap. And it is brought all around, and the rexus has been enlarged a bit. So in this case, what you saw was that I have not done any hydrodissection or any hydrodelineation. Generally, the patients with subluxated or zonulopathy lenses are softer. Here, there is nucleus sclerosis. I'm just creating a central crater, a longitudinal one, a central trench. And then trying to crack it, but the trench is not deep enough. So deepening the trench, and then now you can see that I've got a crack. But since I have not done any hydro, this nucleus is not going to rotate very easily. So I think before beginning the trenching, I should have done some hydro dissection and hydro delineation. But for some reason, I didn't do it. And of course, that is the reason why I'm struggling. So a bit of rotation and cracking of the popping of the nuclear fragment. So here has to be careful because as you just saw, if there is surge, because the capsular bag is lax, it can jump up. Again, slight bit of rotation. So the mistake here was that I didn't do any hydro procedure. And every time you can see the pole of the lens becomes visible whenever the chamber experiences some amount of surge. So I think I've asked the assistant to lower the parameters. Have come out, and I'm going to now you know, try and rotate this. Again, it has not occurred to me that I should try to do some hydro procedure. A two-handed rotation would have been preferable in this case, using two instruments, but I was assisting with one. Another mistake on my part. So if you have a nucleus which does not rotate very easily, it is advisable to use two instruments, either two blunt choppers or two Sinsky hooks, so that so now I have taken two instruments. It is now becoming a little shallow. Sorry. Sorry, I just fast forwarded it. More viscoelastic. And now still persisting with one instrument. And somehow I've been able to now rotate this nucleus to be more accessible to the phaco-tip. So a better approach would have been to use two instruments. I did take two, but I still used only one. And very slowly impaling the nucleus.
ओके मैं ठीक, मेरा भी खत्म है, हम तो आपको बोले थे अब जब बोलेगा मेरा खत्म हो जाएगा।
So slowly this nucleus is stopped and removed. One has to be very slow in these kind of cases. You don't want the nucleus to keep jumping up, the entire capsular bag to be jumping up. And another thing that one must also keep in mind is that once you inject CTR, the posterior capsule is also under some tension, and it is closer to the tip. It's not like your regular convex configuration. It will be more flat because of the CTR. So one has to keep that in mind, and that is the reason why I am using this spatula to prevent any posterior capsular rent. Epinucleus has become free, and that will be aspirated in epinuclear mode. Again, keeping the spatula behind so as to prevent any posterior capsular rent. So it would be catastrophic to have a rent with a CTR in the bag. And putting viscoelastic. Now the other challenge in this case is that with the CTR in firmly in the equator of the capsule, the cortex also gets trapped by the CTR. So now the particle removal is not as routine as your normal cataract. So the removal of the cortex would have to be, sorry, the removal of the cortex would be a slightly different. Have to move the cortex circumferentially rather than pulling it to the center. Again, a bimanual, you can see the direction of the removal, you will see that I will try and move circumferentially. And that is the only way you can get cortex out from behind the CTR. And again, this will have to be slightly, this will be slower, and one has to be very, very patient. See, moving it circumferentially rather than pulling it towards the center, because pulling it to the center will never bring it out completely. You will leave behind some of the text in the equator of the capsule. So this has to be done very slowly. Again, circumferential pull. See here, circumferential pull. And many times it is quite frustrating. One wants to finish the job. One has, put in the CTR, has completed the nuclear removal, but then the cortex is, like being stubborn and not coming out. But here is where your patience will be really tested. But it's worthwhile trying to persist. Again, circumferential removal every time. Bits will come, but so now you can also visible. You can see some vitreous hemorrhage here behind the capsule, and that is because of the trauma. That was not visible very clearly when we began the case because of the nucleus sclerosis. Again, change of hands, trying to manage it from the other port. And the other thing one has to be careful about is that while trying to remove the cortex, one should not engage the capsule, because that would, uh, tear more of the zonules. So hold the cortex. Now you can see that the pull of the CTR becoming visible because of the pull of this. See, you can see here, because of the pull of the cortex from behind the CTR, the pull was becoming visible. A circumferential pull, not a. So such kind of cases must not be dealt in your routine cataract surgery series, but rather should be, when you have one or two cataracts, uh, not a very busy surgical day, so that you're not in a hurry to finish off your cases and you know go to your OPD or go back home. Such cases demand a lot of patience. So I'll just so since the edge was not coming out from the uh, I'm holding the cortex. I've loosened it up a bit from the posterior capsule. Again, change of hands. There was a uh, there was ring that was invented, which actually had multiple bumps, uh, which they said that it would make the cortex removal easier. Uh, I haven't used that ring, but it is also available if you have such cases wherein the cortex is going to be trapped behind. You can use that. So after removing much of the cortex, now loading the intraocular lens. So one must try and use these intraocular lenses with open haptics, not the closed haptic ones, because many times it is difficult to dial the closed haptic lenses in cases with zonulopathy. So it is better to avoid using those. Better use these open haptic design ones. These are easier to place in the capsular bag with weak zonular support. So try and place the leading haptic in the capsular bag, followed by placing the trailing haptic again into the capsular bag, just guiding it. Remember, the capsule is under stress because of the CTR. Now you can with the lens in place and try and remove whatever remnants, if at all they are left behind. And here there was a lot of pressure from the posterior pole. That is why the vitreous thrust was pushing the lens upwards. That's why I've put in this air bubble just to keep the chamber formed. Okay. So I think we have less time, but what I wanted to show here today was that in cases of zonular dehiscence, one can use a CTR, and it can be placed in the very beginning. The other option would be to place capsule hooks which support the capsule in the area of the zonular dehiscence. But here I decided against it, and I probably faced a lot of problems. But many a times the capsular hooks are not a good support, and Dr. Parijat has said that you can do peak procedure in between nuclear management, hydro procedure.
Hydro procedure. Sorry.
Hydro. Okay.
It was typing
Yes,
error.
Yes, that is what I said. I made that mistake, and that is why the nuclear management was slightly more difficult. Yes, I agree with you. But I have used capsular hooks also and put in the CTR at the end also. I've had cases where the capsule hooks themselves have torn the rhexis margin, and I'm slightly wary of using capsular hooks or iris hooks. Never, because they tend to tear the rhexis margin more easily than capsular hooks. But capsular hooks also can tear the rhexis margin, and then your entire procedure becomes even more of a mess. So one has to choose between the preferred instruments in your hands, and whatever works best in your hands should be used. In spite of this being slightly lengthier surgery, but at the end of the day, if you have been able to complete your surgery without creating any more problems and removing the nucleus as well as the cortex and implanting your intraocular lens in place, I think it's a good enough procedure, even though you've had to spend a little larger amount of time, a longer amount of time for the benefit of the patient. So, Anita, I think you missed the Anita and did you missed the injection of the CTR? I don't know whether.
Yes, I missed the initial part. Yeah, I missed the initial part. Yes, the most important part I missed. So I was wondering. Yeah, then I was hearing zonular dehiscence. I thought. So you put it in the initial time. Sometimes some people put it in the end also after the nucleus has been emulsified.
Yes. So
just before putting the lens.
This is what it looked like in the beginning. Can you see?
Yeah.
And,
yeah.
This is. Okay, this didn't go in as well. This is the injection of the CTR. This is an instrument made by Epsilone. Stainless steel, and I prefer to do this using the two-handed technique. So I hold the eyelet of the CTR, and then keep injecting the ring into the capsular bag.
Mm-hmm.
So what this does is it lessens the amount of stress on the remaining zonules.
Yes.
So it is done very slowly. That part of the eyelet you can leave, and then slowly this eyelet coming out can also leave. So this is my preferred technique of putting in the CTR.
This is an injector for the CTR.
Yes, this is an injector. This is an injector. You have to load it into the injector and then inject.
I've never used this. How is it? Usually when I go, I just use the CTR with a forceps, engage
so
it,
you can-
engage it under the capsule, and then put the eyelet in the end. With the sense key, put it inside.
Yes, you can
Is
do
this
that.
good?
This is really. Okay, I think we have only a few seconds remaining. Thank you once again.
What
for
is it
joining.
called?
It's a CTR injector from Epsilone. You can
CTR
ask-
injector, and you inject normal CTR. You just
Yes,
load it
it's
in,
normal. It's normal CTR. Normal CTR. Okay, good
and
night,
then
everyone.
you go. Okay. Okay.
Last few seconds.
Camera. Okay. Okay. Goodbye.
Please, you can go back and see on YouTube. This video will be available on YouTube also. Golden Jubilee Day series day 7. It will be written. You can see there. Okay, Anita.
Okay. Bye.
How to hold and how to inject. Visit.
Okay.
Thank you. Good night.
Okay.
Good night,
Good
everyone.
night.
Good night. Thank you.